This lecture will begin to address some of the drugs that affect psychological function, behavioral aspects, such as anxiety, depression, and so forth. These, of course, are very common in patients that are receiving physical rehabilitation. A lot of our patients are injured. They've been diagnosed with serious illnesses. So there's no question why a lot of our clients and patients are taking these psychotropic or medications associated with psychopharmacology. So very important drugs that we'll start to explore here. Now in part one of these lectures, we'll look at the sedative hypnotic, or what we commonly call sleeping pills, and the anti-anxiety drugs. Then discuss depression and the treatment of the medications used to treat depression. In part two of this lecture, we'll look at the treatment of psychosis, antipsychotic medications, and finally talk about the treatment of dementia, especially dementia of the Alzheimer type. But for now, we're going to begin with treatment of sleep disorders and anxiety. So the primary goals of these medications are, first, if a patient has insomnia or if they have sleep disorders, we're trying to relax the patient to promote quote-unquote normal sleep. We have many medications that will make a patient sleepy. We're trying to make the patient sleep a good quality sleep with these medications, however. We want EEG activity to resemble what would happen during normal sleep in terms of the sleep cycle and entry and exit from REM sleep. So that's where it gets a little trickier. So we'll talk about sleeping pills that try to do this. Treatment of anxiety is almost the opposite. We want to decrease anxiety without causing excessive sedation. Again, it's not hard to calm somebody down and treat anxiety, but we'd like to do that without causing a patient to be sleepy so they can continue to function, do their job, take care of their family. And the primary agents traditionally have been this very important group of drugs called the benzodiazepines. And we'll take a close look at them first. What we'll see is there's been a real emphasis lately in both insomnia and anxiety to develop other drugs to treat these conditions. So we'll take a look at those next. So let's get into the benzodiazepines, or as people commonly call them, the benzos. Some of these cause a lot of sleepiness, and we classify them into this category of sleeping pill or sedative hypnotic. Drugs like astaxanthin, clozapam, temazepam, and triazolam, which is commonly known by the trade name Halcion. And these drugs, especially Halcion, were the real go-to drugs as sleeping pills for probably almost 30-40 years. Now, as I said, we'll see some newer innovations that have tried to move away from this. But these drugs, again, they were a mainstay, and a lot of our patients still are a mainstay in trying to maintain or promote normal sleep. Other benzos cause less sedation, and I emphasize less because in some patients they are still going to cause some sedation. At higher doses, they invariably do cause sedation. But we tend to call them more anti-anxiety drugs because of their relative lesser tendency to cause sedative effects. And of course, the most famous one here is diazepam, which is Valium. It's almost a household word when you think of an anti-anxiety drug. We almost invariably think of Valium. But we see other drugs like chlordiazepoxide, which is Librium, lorazepam, temazepam, alprazolam, and several others. And we see this, you're seeing some tendency for these generic names to have that LAM or PAM ending. Not all of them do, of course. You can see that with chlordiazepoxide. But most of them have this LAM or PAM ending, and they fall into this group of benzos. So this right-hand column is looking more at the ones that are traditionally used to treat anxiety. But I'll stress again that it is relative. At even somewhat higher doses, they can also be used as sleeping pills, and often are in some patients. Now we're going to take a look at how these drugs work. Again, very interesting drugs. So we know that benzos increase the effects of an inhibitory transmitter in our nervous system called GABA, gamma-aminobutyric acid. one of the most common, probably the most important inhibitory transmitter in the CNS. And that's what this is saying here. It's an inhibitory neurotransmitter, very common and extensive distribution throughout both the brain and the cord. And how the drugs work is the benzodiazepine drug and GABA bind to a specific receptor called the GABA subtype A receptor in the brain. So let's take a look at how this. So here you see a schematic of the benzodiazepine receptor, and you have the phospholipid bilayer, and embedded in this bilayer is this large protein shown in the center of this diagram. On the outer surface of the protein, there are binding sites for various chemicals. So we see a binding site for both GABA as well as a binding site for the drug, the benzodiazepine, whether it be Librium or Valium or Xanax or what have you. And the way it works is when the drug binds to its binding site, it allows the transmitter, GABA, to bind stronger and have a more lasting effect. So it's this drug that's causing the longer and stronger effect of the neurotransmitter. As a result, a channel down the middle of the protein opens and allows chloride to enter the neuron. In most neurons in the central nervous system, as we get more chloride inside the neuron, it's harder to excite that neuron. It tends to either be more negative or simply further away from threshold. So simply harder to excite. And regardless of why we see the benzos used, whether it's anxiety, sleeping pills, or even sometimes as anti-seizure drugs or muscle relaxants, there is this common mechanism of action where the drug is causing the transmitter to act longer and stronger. So we get more inhibition, which explains all the therapeutic effects. More sleepiness, less anxiety. Now, as I said, the benzos had really cornered the market on both sleeping pill and sleep disorders and treatment of anxiety for many, many years. Lately, there's been this influx of newer strategies to try to treat insomnia. So let's take a look at them first. So we have what I call the Z drugs. Zolpidem, certainly the most famous of these two, which we know as the trade name Ambien, and a second drug, Zaloplan or Sonata. They're not benzodiazepines. They're not chemically similar to the other drugs we've just seen, but they still work similarly. They bind to the GABA receptors, possibly in a slightly different place. We talk about the GABA receptor having subunits. There's probably 4 or 5 of these subunits. And these drugs bind to one specific subunit called the alpha-1 subunit. So is that a good thing? Well, they tend to possibly produce fewer problems when they're discontinued. And what we'll see is one of the big problems when sleeping pills are used for any extended period of time, more than just a few weeks. When you suddenly discontinue the drug, the insomnia may come back even worse, and it's called rebound insomnia. So we may have less of that with these drugs. But we will talk, of course, about some of the side effects of all. In addition, there's been several other newer drugs, like this drug, known commonly by the trade name Lunesta. Again, it's not a benzodiazepine, but it does have a similar effect, binding to this GABA receptor, possibly at this similar subunit to the Z drugs like Ambien. And finally, we've got this drug called Roserum, which now is the first real sleeping pill to move away from having GABA as its source of action. It functions as a melatonin receptor stimulator or agonist. Melatonin, of course, is similar to serotonin, and we know how important serotonin is in controlling sleep and other aspects of mood. So we've now got this drug that affects melatonin. And of course, melatonin is also associated with over-the-counter products and some other interventions to control sleep. So this drug capitalizes on that melatonin effect. These other 2 drugs, newer options for treating insomnia, away from the benzos, and maybe, again, possibly fewer side effects than the benzodiazepines. So, as in many cases, having these options in pharmacology has given the opportunity for certain patients to find certain drugs that seem to work best for them. So we've seen this addition to the sleeping pill scenario, and we probably will see others contributing. So what then do we have to treat anxiety? What newer interventions? This drug was a nice addition to the benzos. It's called buspirone or Buspar. It again affects serotonin, in this case trying to decrease anxiety by affecting or directly stimulating serotonin receptors. It may decrease anxiety with less sedation and less physical dependence or addiction, which are the two primary concerns of the benzos. So what's the bad news? Well, it's not such bad news. This drug may take longer to take effect. It may not have a very rapid onset, so a slower onset, and it may not be as effective in severe or sudden panic attacks. But still, a patient that has sort of a low-level kind of, I've pictured as a smoldering kind of anxiety, especially older patients, may do really well on this drug. And if it's an older patient that's more prone to sedation, this has become the go-to drug. So we see it used commonly for a lot of patients, especially older adults. Another big improvement in treatment of anxiety has been the use of certain antidepressants. And you can make the case that doesn't anxiety often occur in patients with depression? Absolutely. And in that case, a patient may need treatment of both the comorbid condition of anxiety and depression. But some patients have classic anxiety without symptoms of depression. So we see certain drugs can have direct anti-anxiety, anxiolytic effects. And these are drugs like Paxil and Effexor. And what we're going to see a little later in this lecture is how these drugs work when they are used to treat depression. And we'll see that they affect certain chemicals like serotonin, norepinephrine, and dopamine. So there's no question why these drugs may also be beneficial in other behavioral or psychological type problems. The better news is they tend to have fewer side effects than the benzos and possibly, again, less chance of addiction, which makes them very useful in long-term treatment of people with anxiety. And these are not the only two antidepressants used to treat anxiety. We see a bunch of other ones similarly crossing the line, being able to be used in other psych. So on this chart, you see some classic anti-anxiety drugs, Cymbalta, Lexapro, and you see some of their approved anxiety uses, like general anxiety disorder, but also things like post-traumatic stress syndrome or social anxiety disorder. So this, as I said, has become a growing movement to use antidepressants to treat various forms of anxiety. And again, in a lot of patients, it's been a really nice improvement. And that's not the end of the story. There are other drugs that are not traditional anti-anxiety drugs that have been used clinically. Just to mention a few, Seroquel, a very important antipsychotic that we will talk about when we talk about the treatment of psychosis, may be helpful in curbing anxiety in some patients. Neurontin, very useful drug. We see it used as an anti-seizure drug, but of course used in chronic pain, as a muscle relaxant, and maybe even treating anxiety. And Lyrica, very similar. So we see some of these other drugs crossing this border and being able to have a calming effect without causing overt sedation, and even an antihistamine like Vistaril can be helpful in treating anxiety. So once again, we are not categorizing these drugs into one place and saying you can only be used for that function. If they may have usefulness in some other people in treatment of anxiety, such as treatment of anxiety, why not try it? So what are the major adverse effects? Clearly these are important drugs. We have a lot of patients that have trouble sleeping, that have anxiety. These drugs can be very useful, but what are the problems? For the sleeping pills, we sometimes see this residual or simply hangover effect. A patient takes a sleeping pill the night before. The next morning you're seeing that patient and they're confused, they're a little nauseous, they're disoriented, there's some agitation. If you see this, typically because the drug is still in their system. Either the dose was too high, or the half-life was too long, or both. So if you're seeing it, it's often resolvable by lowering the dose or switching to a drug with a shorter half-life. Interrograde amnesia is a little bit trickier. This is where a patient forgets what happened even before they took the drug. Maybe you're working with a patient late in the afternoon, maybe in their home in the evening, and you're doing something that requires engagement on their part, some transfer activity or putting on a prosthesis, what have you. And the patient's understanding you, they're with you, but later that night they take a sleeping pill, and the next time you see the patient they have very foggy memory or maybe no memory of that last engagement. It's usually due to the same reason. The drug dose is too high or too strong, and it wipes out that short-term learning effect. So again, if we're starting to see this consistently, it can usually be resolved by adjusting the dose or the type of drug. We also see complex behaviors. This is notorious for drugs like Ambien, sleepwalking, or even worse, driving a car while basically asleep, or sleep eating. Patients coming down in the middle of the night and eating extensive amounts, and gaining weight and not understanding why. This is usually due to the fact that the drug is taken, that the dose again is too high, or the drug is taken with another sedative like alcohol. So once again, if we're suspecting this, we can examine the dose or question the patient. Adverse effects continued. We see with both the sleeping pills and the anti-anxiety drugs is that when you suddenly stop the drug, the initial problem can seem to come back even stronger. So stopping a sleeping pill, rebound insomnia, the anti-anxiety drug, an increase in anxiety symptoms. Clearly what you're seeing here is that these drugs are useful short term, but we have to be careful when we start to take them away because of this rebound effect. Falls are a huge issue, especially with the benzos, but we can assume falls are going to be an issue with any drug that sort of quiets down the central nervous system. So that's what you're seeing here. And of course we're going to try to protect as much as possible, go into the patient's home and reduce the chance of falls by clearing out the clutter, throw rugs, removing furniture as much as possible. But falls are still a big problem. Tolerance and dependence, the chance of addiction, seems to be more with some drugs, especially the benzodiazepines. But we have to suspect that tolerance and dependence can always be to some extent a problem with any of these drugs. And finally, recently there's been evidence that the benzodiazepines may possibly be linked to an increased risk of Alzheimer's disease. It is something we suspected for some time. Again, these drugs sort of numb the brain to some extent. And it looks like, again, a large cohort study published recently said that retrospectively, people with Alzheimer's disease were 50% more likely to have used benzodiazepines, and that the link to Alzheimer's seems to be very closely associated with how high the dose was and how long the person took the drug. So we, again, always suspected this possible link, but now it looks like the evidence is starting to really back it up, which should cause, obviously, some concern in using these drugs in our older patients and clients. So our major concerns. First, these drugs don't really solve the problem. They treat the symptom of lack of sleep or anxiety. And I'm not saying they're not beneficial. They are. Started out by saying a lot of our patients are injured. They've been diagnosed with illnesses. And there's no question why they're having trouble sleeping or why they have anxiety. But clearly, these drugs should be used with non-pharmacological interventions like counseling, support groups, and so forth, so that hopefully you can take the drug away and maintain the patient's welfare with the non-drug interventions. And the evidence on this is very clear. To get the best outcome for the patient, drug therapy should be combined with non-drug therapy. So we can hopefully encourage that as much as possible. Secondly, there's often a trade-off. We can see very beneficial effects. The patient that's had a good night's sleep is going to be much more engaged in what we're doing. Or the patient that, if we can reduce the anxiety, becomes much more approachable and engageable. But if the drugs cause a lot of sedation, of course we can't make much progress either. So we're always trying to find this middle ground between the benefit and the possible side effect of sedation. And finally, as I was kind of alluding to, there's been this real trend to get away from the benzodiazepines for both treatment of sleep disorders and anxiety. And I think we're going to see that increase, especially now with this newer evidence about Alzheimer's disease. So luckily we do have these options now, both in terms of treatment of both conditions. And I'm certain we'll see that start to, or maybe continue to be a big issue in the future. We want to now focus on this very important problem of depression. Again, many of our patients have depression for obvious reasons. They've been injured and diagnosed with illnesses, but also because depression is simply very prevalent in our society. So we're talking about what's often considered the most common form of mental illness in terms of the numbers of people, the prevalence, and the incidence. And I won't go through all the criteria that are required to diagnose somebody with depression, but we often consider it a sadness that's incapacitating. The patient can't enjoy their life. We always, at the end of the day, are talking about quality of life issues. And here you've got a situation where this illness is really getting at that problem or causing a fundamental loss of a patient's ability to enjoy their life, their family, their job, their hobbies, and so forth. Now we understand that depression has a neurochemical basis, and that's very important because by understanding the neurochemistry, we can use medications to try to hopefully resolve or support that neurochemical basis. And you can see on this slide there's clearly a difference in the electrical or the activity in the brain of somebody who has depression on the left versus somebody who does not have depression. So once again, this has been a very important thing to understand. By understanding the neurochemistry, we can better treat the problem. And that's what we're going to get into here. So given that we now understand that depression has this neurochemical basis, we have to understand how the drugs are going to try to fix this problem, or at least help the problem. Our current theory is that depression is caused by a defect in certain central nervous system transmitters called the biogenic amines. And there are 3 key transmitters in this group: norepinephrine, which is a catecholamine, dopamine, which we all know about, and 5-hydroxytryptamine, which is serotonin. And the exact problem here that we're going to get into is still theoretical, but we know how the drugs work. All the drugs, the antidepressant drugs we're going to meet right now, have a similar or a common goal. They're going to try to increase or prolong the effects of one or more of these amine neurotransmitters. So let's take a look at the drugs first. So we're going to see several categories of the antidepressants depending on how they work or their chemical structure. We'll start first about talking about the selective serotonin reuptake inhibitors. Then we'll talk about the serotonin norepinephrine reuptake inhibitors. Then a very important group, the tricyclics. A small group, the monoamine oxidase inhibitors. And then see there are actually several others too that do not fit into one of these other 4 groups. So we'll list them first to give you an idea or give you a sense of some of the names of the drugs in these groups. So our first group, the name tells you what they're trying to do. They're trying to selectively affect serotonin in parts of the brain that affect mood and behavior, specifically the limbic system. And here you see several well-known, if you look at the trade names like Prozac and Paxil, Zoloft, these are some of the most famous antidepressants. And again, they tend to affect serotonin with little or no effect on norepinephrine and dopamine. Our second group affects serotonin and norepinephrine, so they're affecting two of the three major amine transmitters. And you see drugs like Pristiq, Cymbalta, Effexor, again, fairly well-known drugs. Their goal, again, being to not affect dopamine, but to have an effect on the other two key transmitters, serotonin and norepinephrine. The tricyclics are probably the oldest, not maybe so well known compared to these newer drugs, but oftentimes very effective. Drugs like, and the triptyline drugs like amitriptyline and nortriptyline have been around for many, many years. They're named for the chemical structure. And as I said, the trade names maybe aren't as well known as some of these newer drugs, but oftentimes these are very effective drugs in treating depression. And we have this small group, the MAO inhibitors. MAO stands for monoamine oxidase. It's an enzyme. These drugs inhibit that enzyme and prolong the effects of the transmitter. We'll take a closer look at how all antidepressants work in just a second. These drugs, again, not very well known, and they tend to be sort of a last resort if the patient has not responded to one of the more traditional drugs or one of the other more selective drugs. They may try one of these drugs. And finally, we've got several other options. Nifazodone and trazodone, complex drugs. They affect serotonin receptors and actually block them to some extent. At the same time, they're affecting serotonin reuptake. And as I said, we'll get into some of the mechanisms here. But this effect, to me, is very complicated. And as I said, they may be an option for certain patients that have not responded to more traditional drugs. Bupropion, Wellbutrin, actually affects two of the three, norepinephrine and dopamine, without affecting serotonin to any great extent. So once again, we've seen this drug sort of stands alone. It's, to our knowledge right now, it's the only drug that really does these two of the three transmitters. Mirtazapine may block the presynaptic receptors that are affecting the release of norepinephrine and serotonin. So again, other drugs, a little more complicated than maybe some of the drugs we traditionally associate, but offering options to patients that probably don't respond to some of the more traditional drugs. So let's start by taking a look at how these drugs work. All the antidepressants we just met prolong the effects of one or more of these transmitters by either inhibiting the reuptake of the transmitter into the presynaptic terminal, and we'll see that's how the serotonin drugs work, the serotonin norepinephrine, the tricyclics, and several others. They do this. That small group we talked about, sort of as a last resort, they work, the only ones that really work differently. They decrease the neurotransmitter breakdown by inhibiting the enzyme that normally metabolizes one of or more of these transmitters. We'll see this schematically in the next slide. So here we have a synapse somewhere in the limbic system, probably. The presynaptic terminal contains one of those three transmitters, norepinephrine, serotonin, or dopamine. And again, we're in a part of the brain that's very important in controlling mood and behavior. And the way this synapse, like any chemical synapse, works is when the transmitter is released, it stimulates receptors on the postsynaptic neuron. But in this part of the brain, and actually in a lot of parts of the central nervous system, most of the transmitter is removed by putting it back into the presynaptic terminal. That's our reuptake effect. It usually occurs in about 60 to 80% of the transmitter that's released. So we don't destroy all the transmitter. We simply recycle it and literally use it over again. A smaller percentage, about 20 to 40%, is destroyed by an enzyme called the monoamine oxidase. But again, most of the transmitter is not. It's recycled. So how do our drugs work? Well, very simple. The majority of antidepressants inhibit reuptake. So after the transmitter is released, it stays outside the presynaptic terminal and continues to stimulate the postsynaptic neuron. What we're doing is getting more mileage out of that transmitter. We prolong its effects, it stays active longer. So as I said, this is how the majority of antidepressants work. And some of them, as we talked about earlier, work on one specific type of transmitter, let's say serotonin. Others affect all three, and some of them affect two of the three. That last group of drugs, the MAO inhibitors, they work differently. They inhibit the breakdown by inhibiting the enzyme that normally breaks down the transmitter, but the effect is the same. The transmitter remains active longer. So this is how the drugs work. And we've known this for some time. The question has always been, how does this effect lead to a possible improvement in mood and a decrease in depression? And that's what we have to take a look at next. So here's the question. Why might an increase in amine neurotransmitter influence decrease depression? And there have been many theories on this over the years. It was theorized at one point that by overstimulating the postsynaptic neuron will decrease its sensitivity, which could bring about a decrease in the depressive symptoms. The latest theory is a little different. Latest theory is that yes, the drugs increase the activity of one or more of these amine neurotransmitters. That we know is true. The increased transmitter activity possibly increases the production of a chemical in the brain called brain-derived neurotrophic factor. And the name tells you a little bit about what it does. It's coming from within the brain, but it has a sustaining or a growth effect on neurons in the brain. Specifically, this substance may stimulate the growth or the formation of new neurons, neurogenesis, in the hippocampus. Of course, this is a very important part of the limbic system controlling mood and behavior. So this is a good theory. This is something we can really hang our hat on now. And the effect is shown schematically again in the next slide. Now, the problems with antidepressant drugs, the adverse effects. The tricyclics tend to cause more of a sedative effect in the central nervous system. They tend to cause anticholinergic, decreased acetylcholine effects, which leads to dry mouth, constipation, fast heart rate, urinary retention. And they also have more effects on the cardiovascular system, more orthostatic hypotension, increased arrhythmias, seizures, and increased risk of fatal overdose is also possible with the tricyclics. The MAO inhibitors, they tend to have more of an excitatory effect on the brain rather than a sedative effect. They can also increase blood pressure, especially with foods, other drugs, and foods that cause an increase in catecholamine release. These are typically foods that contain tyramine, and they're often fermented foods like wine and cheese. What happens is the tyramine increases the release of norepinephrine. The drug prolongs the effects of norepinephrine, and when you get this additive effect, it can make blood pressure go very high. So we try to avoid. This is another important drug-to-food interaction. Don't take these drugs with other drugs that increase norepinephrine release, or with foods that contain tyramine and may also increase norepinephrine release. Some of the newer drugs, like the serotonin selective drugs and the serotonin norepinephrine drugs, are actually generally better tolerated. Seizures are more of a problem, and more GI effects, nausea, vomiting, GI cramping. But in general, the tolerability of some of these newer drugs is better, which has led probably to another reason why they tend to be often prescribed first. even if they're not necessarily better documented at treating depression, often their side effects will be better, which is not a minor improvement. A patient will be more willing to take their drug if they can tolerate the side effects better. Another adverse effect we should watch for is called serotonin syndrome, and it's simply due to the fact that there's too much serotonin release in the brain. So it's possible with all antidepressants, because basically all antidepressants in some way increase the effects of serotonin in the brain. And it occurs simply because serotonin receptors are overstimulated. Serotonin, obviously, a very important chemical in many parts of the brain. The symptoms are very diffuse. You can see that here. We see increased blood pressure, increased heart rate, psychotropic effects like confusion and hallucinations, agitation, sweating, shivering, some neuromuscular or neuromusculoskeletal effects like dystonias, dyskinesias, fragmented movements, jerky movements of the arms and legs, muscle pain, and even GI problems. So this is the problem. There are so many different side effects. It's not like just one specific set of symptoms. Good news, it's usually reversible, but we have to catch it early. If not, it can be fatal, mainly due to the blood pressure or the seizure type effects. So we really want to watch for this. Any patient taking any antidepressant that shows any of these possible problems, be aware of that.
Press pause and read this slide before proceeding to the next one for the answer.
Another good thing that's been happening with antidepressants is that we're seeing, I think, them used more and more to help treat chronic pain. Most of this is off-label prescribing, meaning that they're not specifically approved to treat this problem, but we have clear evidence that they can be beneficial. Drugs like amitriptyline, nortriptyline, we've known for probably 40 years or so. These can be helpful in treating chronic pain, including chronic back and neck pain. So we see these drugs used in symptoms like fibromyalgia, neuropathic pain, headache, and so forth. Various chronic pain syndromes. And as I said, this is not a new finding. Of these drugs, only Cymbalta is actually approved to treat these problems or to treat chronic pain. But it makes sense. They affect serotonin and norepinephrine and dopamine, which we know are very important in controlling various aspects of pain throughout the midbrain and downwards through the spinal cord. So, like I said, it's not a new finding, but I just think we're starting to see more of a comprehensive treatment of pain using these drugs, as well as some of the other anti-seizure drugs like Neurontin and Lyrica, which is often a good thing for our patients. Now, major concerns. The biggest one, in my opinion, is that when people start on an antidepressant drug, there is often a pretty profound time lag before the drug starts to work. We're usually talking about at least a week or two before we can expect to see beneficial effects. But the rule of thumb is you have to wait 6 weeks for most of these drugs to reach peak effects. Now, we have to consider that. This is often a patient that starts on an antidepressant and wants to feel better. and is hoping to feel better. But they've been taking the drug now for a week, 2, 3 weeks, and nothing happens. There's no question why a patient might get more depressed during that initial period. Oftentimes, again, the patient is really hoping for and expecting an improvement in mood. So we have to be much more aware that depression may actually get worse during the initial treatment period. This seems to be especially true in younger people, especially children and teenagers. The reasons for it are unclear, and it may have something to do with the mechanism of the drug. We saw that it probably is going to take time for the drug to have an effect in the brain, stimulate the production of other chemicals like brain-derived neurotrophic factor, and eventually bring about a change or a growth in synaptic activity. It probably doesn't happen after a dose or 2. But still, this is a pretty profound problem. So we simply want to be more aware of that. Watch our patients more carefully during this initial treatment period. And be able to recognize and acknowledge that mood actually may be getting worse. And certainly talk to our patients about this. And some patients will be very open about it and say, yeah, I'm feeling actually worse. That's clearly a red flag. We have to let somebody know, somebody on the healthcare team, know that we've noticed this. We are worried that this patient may actually do something harmful. So probably these are very tricky drugs to work with. There is a lot of variability in the response to the drug, and a lot of patients don't do well on the first time they try to treat them with one of these drugs. And it may take some trial and error. But you can see that the trial and error in this situation is going to be really hard because of this time lag. We can't try the drug for a few days and say it's not working. Officially, you have to give the drug a chance to work, but that chance might involve several weeks. So you have to empathize with the patient, their family, and the caregivers. So we've been talking about classic depression, and of course there are subcategories of depression, and some authorities still consider bipolar syndrome a subcategory of depression. Bipolar syndrome, of course, what we used to call manic depression. The classic treatment here is quite different than antidepressant drugs. It involves a substance called lithium. And lithium is considered an anti-manic drug. If you go to the periodic table, you see lithium. It's an element. It's in the same category or column as sodium. And how it works is really unclear. It's been used for many, many years. A lot of people feel that it stabilizes the neurons that start the manic episode. So if you don't get the manic episode, you don't then get this swing back to the depressive side. Other people think it may be somewhat neuroprotective. Again, stabilizing neurons, protecting them from generating this manic symptoms. But we just don't know. There may be many other effects of lithium that we don't quite understand. Some people think it's an old, archaic drug, but it's still our best treatment for most people with bipolar disorder. As we said, lithium is an element. It's not degraded by the liver. As a result, we have to rely completely on the kidneys to eliminate the substance from the body. The fact is then that lithium can start to accumulate in the body very quickly if there's any problem at all in the ability of the kidneys to get rid of or to excrete the drug. A kidney infection even can have a dramatic effect on the ability to eliminate or excrete lithium. And if it does start to build up, we often get into problems called lithium toxicity. So we're going to take a look at the symptoms of lithium toxicity because, again, any patient on lithium therapy may be subject to this. So what are the ranges that we would like to have in the bloodstream, the therapeutic levels, compared to the levels that cause toxicity? And what you see here is that patients in a maintenance phase, we'd like to have about 0.6 to 1.2 milliequivalents per liter in the bloodstream. If it's an acute manic episode, slightly higher levels, 1 to 1.5 milliequivalents, but toxicity begins at about 1.5 milliequivalents per liter. What that's saying is you may see toxic symptoms at the higher ends of the therapeutic range. if the blood levels get beyond 2 milliequivalents, then it's important to treat it. It can become very serious. So we're seeing a drug that has really a very small margin of error. Even a slight increase over the therapeutic range can lead to toxic symptoms. So what are the symptoms? What can we look for in our patients? So here's some of the classic symptoms of lithium toxicity. In mild stages, patients will have a metallic taste in their mouth. We'll see a fine tremor, possibly in the hands. There will be some GI problems, nausea, and generalized weakness. As levels start to accumulate even further, reach moderate levels, patients start to have vomiting, diarrhea. The tremor increases, they become dizzy. The CNS symptoms now are starting to become more obvious in coordination. Vision gets blurred. At severe toxic levels, the CNS symptoms start to predominate, so patients become confused. They hallucinate. We'll see a nystagmus, or a beating movement of the eyes. Voice gets garbled, dysarthria, and we'll actually see twitching of the muscles in the skin. So what we're typically looking for is this increase. Sometimes it's very rapid, but other times it's more slow and insidious. But we're starting to be more observant about any patient on lithium therapy. Do these symptoms, are they present, and do they start to increase? As I said, we may see some of the mild symptoms even at therapeutic doses. But if they're starting to see these symptoms creep up, it's a huge red flag. It's usually reversible, but we have to catch it early, or there may be permanent damage to the cerebellum. Now, we're always on the lookout for other bipolar treatments. As I mentioned, some people feel lithium is an antiquated drug, even though it is still the best treatment for a lot of people. So they've tried other interventions, which are typically anti-manic drugs. We try to keep the manic phase under control to prevent this swing back and forth from the manic to the depressive side. Anti-seizure drugs, some of the real classic drugs like carbamazepine and valproates, some of the newer drugs like gabapentin and lamotrigine. These might be helpful. Same thing with some of the antipsychotics. Drugs like aripiprazole, clozapine, risperidone, which we will see when we talk about psychosis, may keep this manic phase a little quieter and are often used in that situation where there is an acute manic episode, oftentimes to get it back under control. But in a lot of patients, and some patients may remain on these for longer periods of time, but a lot of patients are then put back on, or we try to get them back on the lithium because, as I keep stressing, that is often our best treatment. So we'll keep our eyes open. We'll see if there are other bipolar treatments because we're recognizing this disorder more often now, and it's always nice to have newer, more effective treatments. So what we've done here is this finishes our talk about treatment of a couple of classic psychotropic issues: anxiety, insomnia, depression, bipolar disorder. And in the next section or part of these lectures, we'll start to look at some of the other psychotropic medications.